Hello everyone, welcome to part 2 of this lecture, which is the cytomorphological approach to salivary gland lesions. So the outline of this part is going to be as follows. First, I shall be completing what was left over from part 1, which means I shall be dealing with inflammatory cell inconspicuous lesions which are cystic in nature. We have dealt with all the solid lesions in this particular group. Inflammatory cell rich lesions, and then I shall go on and show you some slides of non-salivary gland tumors which might masquerade as salivary gland lesions, especially if you do not have access to the imaging findings. They can be very confusing. Then I'll go on and talk a little bit about grading of salivary gland malignancies, a few bits on molecular salivary gland cytopathology. These are going to be extremely brief. Then some discussion of the role of fine needle aspiration cytology in management related decision making for salivary gland lesions, and then an outline of the MILAN system for reporting salivary gland cytopathology. So let's get started with the first of this list, inflammatory cell inconspicuous cystic lesions. So what do we have here? Now, as far as cystic lesions are concerned, we have to remember that these are the two major kinds of cystic lesions, non-neoplastic cysts and neoplastic cysts. The lesions which come under the category of non-neoplastic cysts are obviously the retention cysts, the salivary duct cysts, there are lymphoepithelial cysts, and of course there is this entity which is the polycystic disease of salivary glands. However, a large number of cystic lesions could be neoplastic. Some of them are very well known, like Wharton tumor. In addition to that, other lesions which are more commonly solid or overwhelmingly solid rather, like pleomorphic adenomas, can present as cystic lesions. There are malignant tumors which can show cystic change, and this could be extremely dangerous with potential for pitfalls, and these are mucoepidermoid carcinomas, actinic cell carcinomas, cystic carcinomas, and even metastasis can show cystic change. To be able to identify these cysts as mucinous versus non-mucinous is an important consideration which I would like all of you to keep in mind pertaining to the use of the MILAN system, which is going to be discussed in the latter part of this particular talk. So this is all about non-mucinous cyst contents. You can have a simple cyst, non-mucinous, you just have cyst macrophages, you may not see any epithelial cells. They have a particular way of using MILAN system on these lesions. I shall talk about them a little bit later on. So these are just non-mucinous cyst contents. Now, the next slide shows you something extremely important. So this is abundant amount of mucin, which comes from a mucus retention cyst. Okay, this one is a lesion with an abundant amount of mucin with epithelial cells which, when you go on higher power, show the features of a mucoepidermoid carcinomas. These things have been discussed in detail in the first part of this lecture. The other one could be a non-mucinous tumor like a cystic actinic cell carcinoma, which can present, as I said, as a cyst. So it is extremely important to remember these when you are dealing with cystic lesions. Now, this is what I would like you to pay a lot of attention. This is exactly where I'd like to pay a lot of attention. And that is when you see a mucinous lesion with scanty or absent epithelial cells, you have to be extremely careful that, and remember that it is not possible to exclude a mucoepidermoid carcinoma, and therefore such lesions, and I'm going to talk about it again a little bit later under MILAN system, are not categorized just as benign mucus retention cysts, but they are categorized as ATP of undetermined significance. More of it a little bit later on. Be extremely careful of the next pitfall alert. Squamous cell carcinomas can undergo extensive cystic change. If you see a picture like this with pleomorphic squamous cells, you are not going to make a mistake, but there are situations where the squamous cells can look deceptively benign. So be very careful. And to add to the complication, you have to remember, as we have discussed in the previous talk, that Warthin's tumors can show highly atypical looking squamous cells. So on both sides, it could create a lot of confusion. So remember these facts. This is another pitfall alert, which as far as my practice is concerned, I've been seeing quite a lot of in the last few years. Here, the material looks like mucin, and the submandibular gland area is a place where people take some cosmetic filler injection material, and this can present as a lesion which looks like a salivary gland lesion. When you put in a needle, you get a thick mucus content, and sometimes there could be reactive macrophages in this vicinity which might look like epithelial cells, and I have seen situations where people have misdiagnosed it as a mucoepidermoid carcinoma, or at least put forward the possibility of a mucoepidermoid carcinoma. So with the popularity of injecting cosmetic filler material, especially in this part of the face, just under the jaw, this could look like salivary gland tumor. So please ask the person, has you taken any cosmetic filler material injection? This is a big pitfall. Next, we go on to our next group, and that is the inflammatory cell conspicuous lesions. Right. So again, these could be solid or cystic. Now, this is the major part of the lesions that we come across. So lesions with conspicuous inflammatory cell components could be cystic or solid. Under solid, and there could be a lot of overlap, of course. Under solid, these you could further categorize them or look at them as lesions which are rich in lymphoid cells, lesions which are rich in neutrophils, and granulomatous lesions. The lymphoid cell rich lesions, the first one on your card, should be an intrasalivary gland lymph nodes with features of reactive hyperplasia. Chronic sialadenitis, although can show lymphoid cells, they're usually hypocellular, and that's why I put a little cross mark over it so that you remember. We are seeing cases of IgG4 associated chronic sialadenitis. Salivary glands happen to be one of the glands which could be affected by IgG4 associated chronic sialadenitis. So we should keep that at the back of our mind. There could be benign lymphoepithelial lesions, lymphoreticular malignancies, leukemias, lymphoepithelial carcinomas, and of course tumor-associated lymphoid cell proliferations. Commonly, not very commonly, but the ones which you might show it are actinic cell carcinoma, mucoepidermoid carcinoma. So when it comes to lymphoid cell lesions, this is more or less what your list should be like. The neutrophil-rich lesions, let's talk about acute sialadenitis, but one has to remember that in certain situations, salivary duct carcinoma, like anaplastic carcinomas all across the body, can show a very rich neutrophilic exudate. So you have to be very, very careful about that. Granulomatous lesions like NURLs, granulomatous infectious or of non-infectious etiology. The inflammatory cell conspicuous lesions, I would put 3 under this list: lymphoepithelial cysts, Warthin tumor, or we could even think of tumor-associated lymphoid cell proliferation in a tumor with cystic change. Why not? As I have put over here a cystic TALP, or this tumor associated lymphoid cell proliferation. So I'm going to just show you like kind of a representative pictures of each one of these lesions, because this is an approach kind of a lecture. We cannot go too much into details of each and every lesion. So it is more something which I would like to look at from a differential diagnostic point of view, as I had mentioned in the previous lecture. So this is a representative slide showing a reactive hyperplasia of intrasalivary lymph node. These are the salivary acinar cells, and you have a polymorphous population of lymphoid cells. But as you are going to see a little bit later, this is not like 100% guarantee that we are not dealing with a non-Hodgkin's lymphoma. We are going to come to that. This is one of the big pitfalls in salivary gland cytopathology. But more often than not, when you see such a reactive picture, it comes from a reactive intrasalivary gland lymph node. The next one is a case of a chronic sialadenitis. Now, in a chronic sialadenitis, the number of lymphoid cells are not really that high, but what you see are a lot of salivary duct cells, which is fine, as a result of which, if you remember the previous lecture, it came under the differential diagnosis of basaloid lesions, although they're very hypocellular. But what creates a problem is that sometimes you can have metaplastic and reactive changes in the ductal cells, which may raise the suspicion of a neoplastic lesion. So one needs to be aware of this particular fact. This is a lymphoepithelial lesion. We are going to talk a little bit more about lymphoepithelial lesion just in the next couple of slides. But in the lymphoepithelial lesion, what you find is a lymphoid cell proliferation, reactive cells, and then you are going to start seeing these clusters of ductal cells with kind of an infiltration by lymphocytes. And next slide is something which I have got from the Milan system for reporting salivary gland cytopathology textbook, because I liked these pictures there. So these are, of course, the ductal cells with metaplastic changes with a very florid lymphoid cell proliferation, which is getting admixed with this entire what you find in these aspirates. So you see, so the most important thing over here, the features which you look for are ductal cells infiltrated by lymphocytes. Sometimes these could show metaplastic changes. Now, something about benign lymphoepithelial lesions, and there are some very important points. They may be associated or may not be associated with Sjögren. Now, the parotid gland is involved in over 90% of the cases. They're commonly bilateral. The involvement of submandibular salivary gland is much lower. Okay, it's much less common. It could be recurrent, it could be progressive, and it has a high risk of developing marginal zone lymphomas. On top of it, I think it increases the risk by around more than 40% over a 5-year period of time. Therefore, it is a big challenge. Because the lesions are recurrent and progressive, you might be using FNA as a part of the follow-up procedure. Now, when this particular lesion has become a marginal zone lymphoma in the course of the disease, is very difficult to pick up. So this is a very important challenge in salivary gland cytopathology. On cytomorphology, as I have already mentioned, what you see are ductal cell aggregates admixed with lymphocytes along with a polymorphous population of lymphoid cells with histiocytes, dendritic cells. It is pretty rare to find acinar cells in these lesions. And of course, on the other side, you have to be aware of metaplastic squamous cells and repair cell changes, as a result of which it starts looking like a neoplastic lesion. So it is a very tricky challenge to deal with these lesions. So that's why I have dedicated a slide where I just wanted to jot down the points which we should remember while reporting these kind of lesions. Now the next lesion which I'm going to show you is this is a diffuse large B-cell lymphoma. This is almost a monotonous population of large lymphoid cells. When you see something like this, the moment you have identified the cells as lymphoid, or the appearance, or based on the lymphoglandular bodies on the background, I think you are pretty done that, well, we are dealing with a non-Hodgkin's lymphoma. And if you have immuno, you do run the immune markers and you find it's a B cell and these large cells. So it is a diffuse large B cell lymphoma involving the salivary gland. Not really a big diagnostic challenge. However, if you come across a situation like this, where you are not neither on the side of being a completely polymorphous population of lymphoid cells, or say, for example, a monotonous population of lymphoid cells, you kind of see an admixture. Okay, there are mostly medium-sized cells, some smaller cells. Okay, so you are not really seeing what you expect to see in a reactive lymph node. You have a gut feeling there is something happening here, and I really can't put my finger on it. This is a case of a marginal zone lymphoma, and it is a big challenge to deal with them. And I'm going to talk about it just on this diagnostic problems just a little bit down the line. Right. So let's get over with the other lymphomas. So this is a case of acute sialadenitis. You see this structures, parallel line, like rectangular structures. These are amylase crystals, which are very commonly found in acute sialadenitis. This is a case of a granulomatous sialadenitis with loads of differential diagnoses, which can come infectious, non-infectious. This is an example of a tumor-associated lymphoid cell proliferation. In one of our cases, it's turned out to be an actinic cell carcinoma. As I have said, you can see a lot of tumor-associated lymphoid cell proliferation with mucoepithelial carcinomas too. This one is a Wharton tumor. Once again, a lesion which can show a lot of lymphoid cells, but then you find this tissue fragments comprising of oncocytic cells. Some of them can show you a nice core of lymphoid cells, so you're home and dry. This is a Wharton tumor. So it comes again under the DD of tumors with a rich lymphoid cell infiltrate. Okay. Now this one could be very scary. Here, what you find is a tumor which is very rich in lymphoid cell, but it has got this highly pleomorphic cell with very, very prominent nucleoli. This happened to be a lymphoepithelial carcinoma. So another one of your differential diagnosis. But what is the key challenge? The key challenge is the non-Hodgkin's lymphoma of the salivary glands. And the salivary gland non-Hodgkin's lymphoma, the non-Hodgkin's lymphoma may account for up to 6% of salivary gland neoplasms, mind you. The parotid gland involved in almost 70% of the cases. The most common, unfortunately for cytopathologists, is the extranodal marginal zone lymphomas, okay, followed by DLB, diffuse large B-cell lymphoma, followed by follicular lymphomas. Now, extranodal marginal zone lymphoma, I think I was talking about a little bit just a while ago. They are about 20% are associated with Sjogren's, and yes, creates about a 44 times rise with a 5-year cumulative risk. Now, and because of this pre-existent chronic disease and the indolent course, as I said, it could have a kind of a relapsing and recurrent course, it hampers our diagnosis. It may transform to high-grade lymphomas. On imaging, around 35% is unifocal. It could be multifocal in 65%, which may give you some clues which are further refined with CT and MRI, but this again is not too easy in a background of Sjogren's. So let's look at these triumvirate of slides here. So to your left, we have a lesion, you have something in the middle, and you've got something to the right. So let's try and guess what these are. Here we see a pretty clear-cut evidence of a polymorphous population of lymphoid cells, starting from small lymphocytes right up to immunoblasts. Okay, so in such a case, we might think that, well, we are possibly dealing with a reactive lymph node, and most of the times you're going to be right. In this case, you have a rather monomorphous population of large lymphoid cells. So in this case, well, you feel that I think we are dealing with non-Hodgkin's lymphoma, possibly going to turn out to be a diffuse large B-cell lymphoma. Now, this case again is something which I've shown you before is a problem, and it is a problem because the population is not really polymorphous, it is not really monotonous, it is a kind of a mixture of cells. There are small lymphocytes, but seems to be a large number of intermediate cells, some cells with clearing of cytoplasm, who knows? So this was a reactive lymph node, a diffuse large B-cell lymphoma, and this turned out to be a marginal zone lymphoma. So this is a picture of a intrasalivary reactive lymph node. You can see a very clear-cut polymorphous population of cells. You can be pretty certain, but still you could have cases of marginal zone lymphomas who could just look just like this depending on where your needle has gone. So be very, very careful. If a patient with salivary gland tumor keeps coming back to you and every time you're calling it a reactive lymph node, okay, you have to be careful. Most likely you're dealing with a marginal zone lymphoma with a very indolent course. This is a diffuse large B-cell lymphoma. No problem here. Large cells, pretty monotonous population. Diffuse large, you do run some immunos, confirms your diagnosis. Diffuse large B-cell lymphoma could be any other lymphoma too, but just showing you a case which turned out, which was a diffuse large B-cell lymphoma on immuno and later on histopathology. Right. These are the problems, and these are the cells where you have mostly intermediate size cells, a few small lymphocytes, some clear cells, you can call them like the so-called monocytoid B cell kind of stuff which you see in marginal zone lymphoma. When you see a picture like this, you should start getting a little bit worried. So these to me are not that of a problem, because if I see a picture like this, okay, I am always going to throw in the possibility of a marginal zone lymphoma cannot be ruled out. I'll ask for flow cytometry. Okay, but what I'm worried about is the fact that sometimes the entire lymph node may not be involved, and you may find areas which look just like this, right? And then you move to another part of the smear or to another smear, and you're going to see something like this. So whether it's because of smearing or whether it is truly a kind of a semi-monotonous kind of a population of cells, if I don't know whether I should be using such a phrase, I really don't know. But when I see something like this in any part of the smear, I start getting worried. Right? So marginal zone lymphomas, once again, as you can see over here, the population looks rather looks quite polymorphous, right? But still, again, there seems to be some kind of an increased number of intermediate, and some of the cells are large cells. Here has a bit of a monotony. Here again, depending on your your magnification. Once again, a little bit of increased intermediate cell. This I have already discussed before. So this is a kind of a mixy kind of a picture which you find in marginal zone lymphoma. We really do not see the typical polymorphous population most of the time. You see a population of intermediate size cells, lesser number of small lymphocytes, and this is what you are going to see if you just put them together. So you see cellular smears with polymorphous population of cells with a predominance of intermediate size cells, not really small, not really large, and with a lesser admixture of small lymphocytes. You can see some monocytoid B cells, some plasma cells, some lymphoplasmacytic cells, and immunoblasts may also be noted. So you can see this kind of a polymorphous picture, but a predominance of that. So where exactly you draw a line, it's up to you, to your experience, where you have seen stuff, where you have made a mistake, where you have been correct. So all these add up to this kind of a gray area in cytopathology to point the clinician to the right direction. But the tricky part is that if you believe in the fact that if you see tangible body macrophages, it's a benign lesion, you're going to make mistakes, because these cases may show tangible body macs. Okay, they may show lymphoepithelial aggregates, but such aggregates can also be found in some benign lesions. So you have seen those, say in lymphoepithelial lesions. So it doesn't really prove anything. So CD20 positive, right? CD5 negative, CD23 negative, CD10 negative, Ki67 is low. So the consistent marker is CD20. There is no clinching marker to make a diagnosis of a salivary gland MALT lymphoma, unless and until, of course, you go ahead and run the aspirate flow cytometry, which is an extremely important diagnostic modality. And in this case, this has got a restriction of the upper light chain, so that really makes it easy for you to put forward the diagnosis of a marginal zone lymphoma. So flow cytometry is very important. So when you are in trouble, you should use flow cytometry. In fact, Why not use flow cytometry in most of the cases where you see a lymphoid cell reach in FNA from the salivary gland, unless and until you are absolutely certain that you are doing with a non-lymphoid or an epithelial tumor. It is better to run that because sometimes even reactive lymph node can show monoclonality. Okay, so people have made mistakes. One has to be very, very careful. Flow cytometry can come to your rescue and guide you to the correct diagnosis. Very important. So if there is one part where I would like to do flow cytometry in fine needle aspiration cytology, this is exactly where it is going to be. Right. So as far as lymphoepithelial cysts are concerned, now we are moving on to the cystic lesions. The associations could be with HIV and Sjogren's. The HIV-associated lesions do not usually progress to lymphomas. The Sjogren-associated lesion does. And the lymphoepithelial cysts in children may exhibit monoclonality, but they do not progress to lymphoma. So more or less the same picture as a benign lymphoepithelial lesions, which you have seen before, is a solid lesion. It could also be a cystic lesion, right? And you could have all kinds of changes, which you can sometimes find squamous cells, and you will find metaplastic ductal cells and infiltration by lymphocytes, sometimes some spindle-shaped cells. This is a picture of a lymphoepithelial cyst. Right. Now, let us now move into some non-salivary lesions, which were referred to our clinic as salivary gland lesions. Now, some of them actually had imaging, and the radiologists didn't pick up these lesions as salivary gland lesion. They were sent to us actually as salivary gland lesion even after doing imaging. I don't want to criticize the radiologists, but these are cases which we have seen in our department. Now, take a look at this one. This is a lesion from, I think the angle of the jaw came with a salivary gland lesion. You see this basaloid cells, but then you see this multi-nucleated, massive, giant cells, right? You could find some areas of calcification here, maybe a little bit here. So this happened to be, I think you guessed it, a pilomatricoma, all right? Calcifying epitheliomal herb. Not going to go too much into the details of that. Let's look at this one now. This is a lesion which looks ominous like a salivary gland lesion. You have once again a tumor at the near the angle of the mandible, and sent as possibly a salivary gland lesion, or is it a lymphoid lesion? Is it a lymph node, soft tissue, whatever? You have these, like, there is a clue. You have got these cells which are arranged in balls, right? Showing a significant amount of anisonucleosis. Okay, seems to have some kind of a magenta colored granules in the cytoplasm. This was a carrot body tumor. I am sure you must have guessed it. This was, I think it was around the 16-year-old or 17-year-old female patient who came with a well-defined soft tissues, swelling in the region of the submandibular gland. It was again sent as a salivary gland lesion, and I was really shocked when I did the diff quick. This, of course, is a PAP. It's turned out to be a PNET, right? So there could be a lot of surprises. This one again was sent as a salivary gland tumor and turned out to be a lymphomatous lesion with this kind of a ropey collagen, and this cells just admixed with fat, happened to be a spindle cell lipoma. So next, I'm going to just spend a little bit of time, just one slide each, on the grading of salivary gland carcinomas, and then a little bit of time on the molecular cytopathology of salivary gland. Now, when it comes to the grading of the salivary gland carcinomas, most of the times the grade is defined by what you call the lesion. So if you call something a lesion as an actinic cell carcinoma, secretory carcinoma, epithelial, myopithelial carcinoma, it means that you have called it a low-grade carcinoma just by designating them as such. Whereas on the other hand, if you call something a salivary duct carcinoma, small cell carcinoma, large cell neuroendocrine carcinoma, lymphoepithelial carcinoma, and all of these have been dealt with in most of them in the previous part of the talk. Lymphoepithelial carcinoma, of course, I spoke about in this part. This is by definition high grade. However, there are some carcinomas which can have multiple grades: mucoepidermoid carcinoma, adenoid cystic carcinoma, epithelial carcinomas, of which most of the time this grading issue you are going to face in mucoepidermoid carcinomas. I have spoken about it in detail in the previous lecture. But what is the utility of grading stuff on FNA? The main utility is that if the surgeon knows that the tumor is high grade, they are candidates for elective, selective neck dissection for lymph nodes. So that is the reason why grading of salivary gland carcinomas are important. Now, so what is the role of FNAC in management related decision making? So, number one, requirement for staging imaging procedures. For masses involving the parotid, all patients must undergo preoperative cross-sectional imaging to determine the extent of the lesion and the possibility of complete resection of the primary lesion with preservation of the facial nerve. However, if the lesion is small, located laterally in the parotid with a benign cytology diagnosis, so you call something, say, a Warthin's tumor or say a pleomorphic adenoma, it may not require cross-sectional imaging. The patients with malignant diagnosis on imaging will require further imaging of regional lymph nodes. So you have to send the patient back for imaging of regional lymph node. Next, do we need to discuss this in a multidisciplinary meeting? Any lesion which is not unequivocally benign, that means anything which is atypical, suspicious, malignant, should go for multidisciplinary meetings. FNA can also tell the clinicians about the feasibility of clinical monitoring. How? Because asymptomatic benign lesions with a low risk of malignant transformation like Warthin tumor, pleomorphic adenoma in deep lobes of an elderly patient, or patients who wish not to take the risk of facial nerve injury may be followed up clinically. So what is the role? So apart from giving this, helping the clinician with this decision-making procedure, benign tumors or indeterminate tumors under observation should so when do you do repeat FNA? Undergo repeat FNA if there is evidence of growth, pain, or facial nerve involvement. So even if we're following them up with imaging and with clinical through clinical findings, if you see these features, rapid growth, pain, or facial nerve involvement, you should send the patient for FNA. And of course, the indication for neck dissection: patients with clinical evidence of cervical lymph node involvement will undergo therapeutic neck dissection. In nearly all cases, patients with low-grade malignancies can be followed clinically without a neck dissection if clinical and imaging findings do not show any evidence of metastatic disease. Patients with high-grade malignancies are candidates for elective and selective neck dissections, as we have mentioned before. So, one slide just on the molecular cytopathology of salivary gland tumors. Yes, we can use FNA material for molecular cytopathological studies, and these are some key facts to remember. Now, in pleomorphic adenomas, there is a PLAG1 rearrangement, PLAG1 gene rearrangement, which could be associated with CT-NNB1 or LEF, right? These are the facts here. Now, this is seen in pleomorphic adenoma as well as salivary duct carcinoma and epithelial myoepithelial carcinoma, which can arise on the pleomorphic adenoma. So if you have a salivary duct carcinoma, you want to know, did it arise on a pleomorphic adenoma? Because sometimes the benign tumor could be completely overrun. If you see a PLAG1 gene rearrangement, this is indicative of the fact that this is on a pleomorphic adenoma. The adenoid cystic carcinomas can show MIB rearrangements involving MIB and the NF-IB gene in about 50% of the cases. So if you don't see them, it doesn't mean that it is not an adenoid cystic. Secretory carcinomas show the ETV6 gene rearrangement involving NTRK3, RET, and MET. Mucoepidermoid carcinomas, so this well-known MAML2 gene rearrangement with CRCT1 and CTRCR3. Now, the important fact, again, not all the cases. 75% of low-grade mucoepidermoid carcinomas, so the gene rearrangement, and only 45, excuse this typo over here, in high grade. So there are a lot of tumors, more in high grade, which may not show the gene rearrangement. And importantly, the reports of Warthin tumors with MAML2 translocations are most likely low-grade mucoepidermoid carcinomas resembling Warthin's tumor. I think we have spoken about this in the previous lecture. So, let us, before we go into the Milan, what are my top 5 concerns related to salivary gland FNAC? And this includes what we have discussed in the first lecture and this lecture up till now. So one is low-grade mucoepidermoid carcinomas masquerading as mucus retention cysts, mistaking epithelial myepithelial carcinomas, and I think I dedicated a significant amount of time in driving home this point, as pleomorphic adenomas, and I told you the small little hints that you can get which helps you. Mistaking marginal zone lymphomas as reactive hyper. This was a major part of today's talk. Missing metastatic squamous cell carcinoma in a sea of squamous cells which may look just benign, right, and with a lot of cystic changes. And very, very important, not having prior knowledge of imaging. Forewarned is forearmed. So finally, the Milan system for reporting salivary gland cytopathology. I can tell you this is not going to be an exhaustive lecture on the Milan system. This should be a full lecture on the Milan system, but I'm just going to give you a kind of an outline of the practice points that you can use at work. So, my approach is to use the cytomorphological features to the best of your ability, and that is why I have dealt with the approach first in conjunction with clinical and imaging findings, along with the use of adjunctive tests as per availability at your place of practice, to reach as close as possible to a diagnosis using this approach that has been discussed so far, and then try to see where in Milan it fits in. So if you start looking at a smear and say, okay, what am I going to do? It's going to be Milan what, right? No. So try to use an approach, try to come to a diagnosis, and then depending on what you come to, try to fit into Milan and not the other way around. I hope I've been able to get through what I'm trying to say here. Right. So the Milan system comprises of like 6 categories. Non-diagnostic, category 1, non-neoplastic, ATP of undetermined significance, neoplasms, which has got divided into 2 groups, benign and SUMP, that is salivary gland tumor of undetermined malignant potential, right? Suspicious of malignancy and malignant. Each one of them, I put a ROM, which is the risk of malignancy, with non-diagnostic, and that is very, very significant. It can have a 25%, so it's pretty high. 10% in non-neoplastic, and that's why non-diagnostic should be repeated. You just can't just leave them alone, because 1 in 4 cases are actually neoplastic, so be careful. Non-neoplastic 10%, which is pretty good. ATP of undetermined 20%. Benign has the lowest risk of malignancy. So when you are sure a lesion is benign, the risk of malignancy is extremely low. So that's why it's very good to give a benign. Most of the salivary gland tumors, especially those in the parotids we've discussed in the first lecture, are benign. So that's why FNA is pretty good. Actually take out the benign lesions pretty confidently. Right. So SUMP has got about a 35% risk of malignancy. Suspicious and malignant have got a very, very high risk of malignancy. So that's why it's something which we should keep in mind as far as we are concerned. So when you are using these particular categories, I think I have made a mistake here. This is possibly much, much higher. But anyway, so that's where we go to now. So Milan 1 non-neoplastic, the minimum number of cells required as a criteria for adequacy has not yet been defined, like in the thyroid. Okay, the situations where an aspirate is considered diagnostic without epithelial component are abundant inflammatory cells. So if you see an abundant amount of inflammatory cells, or if you see matrix component associated with neoplasm, like you see some chondromyxoid matrix, you can discount the cells that are required. Now, personally, I do not believe in this particular number. I think the entire judgment has to be based on quantitative as well as more than the qualitative criteria. So it is necessary to take into consideration the qualitative and quantitative aspects as well as imaging findings. Non-mucinous cyst fluids without epithelial cells is categorized as non-diagnostic. Cyst fluid only, something which we just discussed. But if you have a mucinous cyst fluid and you do not have epithelial cells, right, you call it AUS, right? So if it is non-mucinous, it is non-diagnostic. Just say non-mucinous cyst content, just like what you do in thyroid cytopathology, right? You only see cyst cells, cyst counts, non-diagnostic. And then the clinician looks at the imaging and decides on the further course of action, right? But if it is a mucinous cyst in the salivary gland, you just cannot call it mucinous cyst contents and just leave it at that, or call it non-diagnostic. No, you have to call it AUS and follow the protocol of AUS. Now, the cellularity paradox, this is what I'm talking about. There is no point counting the number of cells. For example, in this case, we have a lot of cells. There are benign salivary acinar cells, which is absolutely fine. You were thinking of a salidinosis. But if there is a well-defined mass lesion there, this is no good. So this is a non-diagnostic aspirate. However, in this case, you have just a few cells. Just in one corner of a smear, you maybe have around 7 or 8 cells, but looking extremely pleomorphic. Turned out to be, by the way, a salivary duct carcinoma. This is diagnostic, right? So that's why the using cellularity is no use unless and until you are correlating it. And once you correlate, I don't think that 60 cell counts, which is being proposed by many experts. I really don't believe in that. Okay, MILAN II, the non-neoplastic, easy ones: salidinitis, acute chronic granulomatous IgG4 related disease, salolithiasis, salidinosis, reactive lymph nodal hyperplasia, benign lymphoepithelial lesions, oncocytosis. So these are the non-neoplastic. I'm not going to go because most of them we have already dealt with. It's just to show you where to place these things in MILAN. That's the reason why we have just listed the lesions here. We're not going to go into any details of these lesions because you know what they look like. You have learned the approach of how to get to these diagnoses. Once you do that, next part is easy. You have to just know where in MILAN you have to place it. So MILAN III, ATP of undetermined significance. So what are the conditions where we have to put lesions as ATP of undetermined significance? Sometimes the specimens may have low cellularity, they have preparation related artifacts, but you look at the cells and you see that, well, there is something happening there. Okay, you just can't leave it as non-diagnostic, right? So these are the cases where we call them as ATP of undetermined significance, right? Sometimes you can have reactive changes, reparative changes. I showed you sometimes you can see that in association with chronic salidinitis, squamous oncocytic metaplastic cells. You think that it could be benign, but then you really can't rule out the possibility of a neoplasm, ATP of undetermined significance. Mucinous cystic lesions with absent or scanty epithelial cells, always ATP of undetermined significance. There is no other way out of that. Never forget that. I've spoken about lymphoid cell rich lesions where you are in between kind of a place. You do not possibly have access to flow cytometry, and you need to put this again, some of the lesions where you feel that there might be a marginal zone lymphoma lurking down somewhere. We cannot rule it out. ATP of undetermined significance. The last one, we really don't see that often. Once in a while, you just see some spindle cells. Think there could be a neoplasia, but you don't. You're not very sure, so that again is going to be ATP of undetermined significance. Pitfall alert, once again repeating it. If you see a mucinous lesion, scanty or absent cells, in such cases it is not possible to exclude a MEC. I've already said it before, but I'm saying it again just to drill home the point. If you see a cystic mucinous lesion without epithelial cells, very scanty epithelial cell, call it AUS. Do not call it benign. Do not call it non-diagnostic. Now, neoplastic lesions benign, Pretty easy list. Pleomorphic adenoma, most of the time you are able to pick them up very well. Don't complicate things. I have seen people complicate pleomorphic adenoma with, calling them suspicious and other kinds of things. Most of the time, what looks like a pleomorphic adenoma, they are pleomorphic adenoma, right? Warthin's tumor, oncocytomas, lipomas, schwannoma, lymphangioma, hemangioma. I do not come across these lesions that commonly. Now, this is where the meat of the discussion is. Neoplastic salivary gland neoplasms, uncertain malignant potential. Now, there is a particular slide, if I remember, I had shown you, where you have lesions, which I had shown, solid lesions, right? And cells were basaloid, cells were oncocytic, cells were clear, right? So cellular basaloid neoplasms, if you remember the slide, cellular oncocytic neoplasms and cellular neoplasms with clear cell features. So these are some of the representative slides. I'm not going to go into the diagnosis. If you see something like this, cells look basaloid, you are unable to differentiate between a pleomorphic adenoma and a basal cell neoplasm. And a basal cell neoplasm, as I told you, are lesions where to be absolutely certain that these are not basal cell carcinomas. You cannot do it on FNA because you need to see the presence of invasion, which you can't do on FNA. Sometimes highly cellular basaloid lesions where you are unable to differentiate between a basal cell neoplasm and adenocystic carcinoma or a polymorphous low-grade adenocarcinoma. It is better to call it basaloid tumor, salivary neoplasm of undetermined malignant potential. This is the term which we use. We have spoken about oncocytic tumor. This is one such to an oncocytic tumor. We are not sure, am I dealing with an oncocytoma? Am I dealing with something like an actinic cell tumor? Another place where you can use this phrase, cellular oncocytic neoplasm, salivary gland tumor of undetermined malignant potential. And then there is another, which is a clear cell type of salivary gland tumor of undetermined malignant potential. We are not very sure. You've used your immunohistochemistry, if you have them, and you really want to put them in one of these categories, you are unable to do so. That's the time when Milan can come to your rescue, but make sure that you have exhausted all the means. Do not use Milan just like a waste bin just to get the the slide off your table. Okay, playing too safe. No. Now, suspicious for malignancy, usually with highly abnormal cells are present, but you are unable to confidently render a diagnosis of malignancy because of low cellularity, preparation artifacts, or rich admixture of benign salivary gland cells, right? So these are almost always malignant, right? They're almost always malignant. But what happens is that when you see these lesions, you know they're malignant, but they're too few, so you really don't want to risk it, so you just call it suspicious. And of course, malignant, actinic cell carcinoma, these are a list of malignant tumors which we have already discussed. No problem as far as placing them in the category of Milan 6 or malignant is concerned. So with this, I thank you all for your time. I hope I have been able to remove some of the confusions which you might face while dealing with salivary gland cytopathology. Thank you very much. Good luck.